Hi, I'm Siobhán Fletcher and welcome to the latest edition of our newscast. Now, you might have heard a little bit about it this week already. This year's Health Services Mandate put forward to Manx Care from the Department of Health and Social Care, and then the subsequent operating plan that the health body has then put together. Now, this year's mandate is all about modernising and making health services more efficient by moving them to the right place at the right time with the right person, or at least that's the message from the Health Minister, who's been hitting back at accusations that it evidences the largest assault on NHS care the island has ever seen. The health body says it wants to develop out-of-hospital provision in dental, GP and pharmacy services and accelerate a home-first approach to move more services into the community. But what does that all actually mean, and will it work? Well, I sat down with Chair of Manx Care, Wendy, Reid, and Health Minister Claire Christian to find out more and to clear up some of this confusion around cancer screenings. First of all, I think before we jump into both documents in more detail, I guess the first thing that's obviously caught the attention of the Manx public this weekend has been the cancer services. So I guess before we get into it, just to be sort of crystal clear here, what's happening with screening on the island?
So there are currently no recommendations or any supported recommendations to change the standards for cancer screening on the Isle of Man. And as it's been advised, I think by Public Health this afternoon, the Director of Public Health informed me that the Public Health have not recommended changes to the current cancer screening standards. And they will be doing a clinical review over the next 12 months.
And so why is that mentioned in the mandate then, that that's something that could be reduced?
So it's in the mandate to basically signal that the review is taking place. Actually, there's part on page 5, there's part of the mandate which is exactly the same as it was in the last two iterations of the mandate.
And so I guess looking at the overall mandate in general then, we spoke to former Health Minister Laura Hooper last week, who said that the mandate was evidence of forthcoming horrific reduction in service level for people of the Isle of Man. Do you agree?
I don't agree with that statement. Both the Department and Manx Care acknowledge that there are challenges to delivering our healthcare services within budget, even with the additional 25 million made available in the budget for 2025-26. But the changes set out in the mandate and operating plan aim to modernise and make the services that we're delivering more efficient by moving them to the right place at the right time with the right person.
So that, and I can jump to you, maybe Wendy, on this one, that obviously is this home first, potentially, that approach. How is that going to work?
Well, I think it's about making sure that people have care close to home when it's appropriate. So we are looking to shift care out of hospital to community services where we can. We know outcomes are better for people. People are living longer with multiple conditions. The best possible care closest to home is going to be the best for outcomes. And the way we're going to do that is there's further investment in general practice. There's investment in general practice services, for example, physiotherapy, able to go and see your receptionist at the GP service and go to a physiotherapist rather than go round the loop of referral into hospital. And also being discharged from hospital sooner, being more active in the community with support from our district nurse teams, our intermediate care teams. So there's a number of layers to that, and it's not an either or, it's both and it's a really positive step to improve the health overall.
So then for the public, are they going to sort of suddenly be able to get GP appointments and dental appointments?
There will be an increased availability around GP and dental appointments. The word suddenly is always interesting. This is a transition that we're making, and with any transition there are elements where things will go more slowly and things will then suddenly happen. But yes, the expectation is over the course of this year we'll be increasing the access into primary care.
Why are we sort of moving to this sort of unproven model for the Isle of Man? It's like a different model than anything we've ever had here. Why is the answer then to the problems that we're facing in the health service to come up with this completely new model versus what we currently have?
Well, this isn't a new model. This is the best model, and it's the modern approach to excellent healthcare. And it's where everyone is looking in Western healthcare to improve primary care and health promotion, disease prevention services. That's public health and population health. And that is the only way in which we will end up with sustainable health and social care systems for the future. So it's not a matter of it being unproven at all. The public tell us they want more access to their GPs. We know there's academic evidence that excellent primary care has excellent outcomes at all levels, but it's only one layer of the care. We will still be providing secondary care in Nobles, indeed increasing elements of care that we'll be doing in Nobles as we bring back tertiary cases from Chester, Liverpool and places like that. We'll be bringing back care when we can. So I think we've called it repatriating in the operating plan. So we're looking at a whole complex matrix of how we deliver care in the future.
Closer to home, obviously, there's the first level that Professor Reid has spoken about, in the sense that we're making those changes within the GPs. So basically, if you're going to see the physio first, you no longer need to go and see that GP. So that frees up the GP for that appointment for people who do need to go and see. And then, as Professor Reid said about repatriating people back here, I know that I've had spoken to many constituents, not just from my own constituency, but across the island, where they've actually rung me and said, I didn't need to go for that appointment in Liverpool, or I could have done that on the phone, I could have done it virtually, is there no ways? And actually the public are really concerned about that, and they're really helpful to suggest, I would be happy to do that, on island. And it's about looking at that, because there is a cost to that no other healthcare, apart from possibly Jersey or Guernsey might have, because they might be sending to other jurisdictions, but there's no other healthcare in the sense that the UK don't have that situation where they're sending their patients somewhere else for that treatment in the way that we do. So I think that's we've listened. The GP appointment is very, very one of my. When I spoke to Professor Reid when I took the position. It was one of the really big important factors for me, that we need to improve that service. But as Professor Reid said, it's not something that's going to be a sudden change. The mandate is definitely something that sets the scene for the year, and it will take time for those processes to be embedded and changed.
Alongside that, in regards to the emergency department, the endeavour is to maintain ED waiting times. So that's that 4 hour, either being transferred, discharged, admitted. But then immediately in the next sentence it says, but we're constraining and reducing elective activity, which we've known about for a while now, and that could have that negative impact on that. So why not just say we're expecting an increase in wait times in the emergency department this year? Well,
I think that the question really relates to how people flow through clinical services. And I think we've tried to be very honest with where the risks in this year's mandate and therefore in the operating plan sit. But I think what we're looking to do is to try and avoid those constraints in elective activity by improving our productivity and efficiency. There are a number of things that will have to happen in order for that to be effective, and that's why we can't really predict at the moment. But there are other areas. For example, if we have more access for general practice over the course of the year, then we would expect to see fewer people having to come to the emergency department. So I think there's a number of clinical pathways that we can look at to try and reduce the impact on people having to come to A&E and sit and wait, but also how we manage people once they're in the emergency department is completely different to, for example, when I first qualified a very long while ago. We're now looking at making a decision, and indeed the 4 hour target is quite controversial in certain parts. And can you make a decision? Can you manage that patient? Can you deliver the care they need and then transfer them back home? Those are all areas that we really need to look at in terms of improving the outcomes for people at that time.
And I think that, and it's just on that 4 hour, I spent an afternoon going around the hospital recently, and obviously one of the main areas I wanted to go into was ED. And speaking to the clinicians there, and when they talked about the 4 hours, for them, it was very much they're not going to send someone home at 3 hours 59 minutes because just to hit that target. If it's sensible and clinicianally right, and for the better of that outcome of that person, for them to stay for 6 hours, absolutely. That's absolutely key. So we can't get fixated with those 4 hours. I trust the clinicians to make those decisions. They are the best people to do that. So it was really helpful to understand their priorities is the person and the patient first.
And that relates to, as well as sending people home, why would we admit somebody if we can actually sort out what they need sorted out and then get them back into their community, get them back to family and friends, and indeed into a system that will support them around, which is why we started off this conversation with care closer to home.
Mm-hmm. Obviously, putting my positive hat on, if you can get that, then that's excellent, like more GP appointments, more dentist appointments. But can you see why there's the issue you're probably going to be battling with here is the public perception that at the minute you can't get that? And a lot of it, oftentimes when I've had conversations with people within Manx Care or within Department of Health, you're having a lot of recruitment issues. That's not a secret. So how are you going to tackle those sorts of things to be able to boost up that availability for appointments?
Well, it's my first year as chair here, but my understanding is that when Manx Care was formed, we were running around 22% vacancies in clinical posts. And we now run a vacancy of around 7 to 10% is my understanding. So we have filled a large number of clinical posts. We've reduced agency and bank spend. And that's not just important financially, but that means that we've got more substantial clinical teams. And as a clinician, you don't work in isolation, you work in a team. So recruitment is something we keep a laser focus on because we want the right people with the right skills in the right place, doing the right job, and they need to be in the right numbers. So we're very aware of that challenge, but I think we've shown that we can improve and that we can develop these clinical teams to work effectively.
There are, though, a number of things that could be classed as cuts within the document, whether that's because you're trying to move towards that home first model or whatever it may be. For example, you're going to reduce acute hospital bed capacity. What does that mean for people coming to the hospital who need those beds?
I think there are two elements to this. So I'll answer the operating plan response to that, which is overall we will have enough bed capacity across the Isle of Man. It may well not be in Nobles, it may be elsewhere. But, for example, if we can discharge people following day case surgery rather than staying overnight where that's clinically appropriate, then that will reduce bed usage. If we can make sure that people have preoperative assessments, that means they're not waiting in a hospital bed for those to be done, that will reduce bed usage. There's all sorts of very well understood operational mechanisms that we perhaps have not focused as much as we could do. But again, with a stable, engaged workforce, looking at this through clinical pathways. We use the benchmarking of getting it right first time, the GIRF methodology, which is well established in England, and it's something that we're really using to drive forward our productivity. So from the perspective of, it's not the number of beds, it's how effective you are at using them. And that balance will be shifting towards the community starting this year.
Yeah, and if I can just follow up with that, just with another example, because, I went to see at Manannan Court last week and speaking to Ross about exactly this topic. What would that mean? What bringing services back into the community? What does that mean in terms of beds for in Manannan Court? And he, very clearly said, look, this is very much a transition, when we put a mental health practitioner into the community, and there's one working very successfully in the west of the island right now, and that has made a huge impact on the man in Court and who is needed, needed to go into there. And once we start to look at mental health practitioners elsewhere on the island, it'll be really great to see the effect. And actually, if you don't need as many beds in a year or 2 years down the line, it's making a cost efficiency because you're seeing that person in the community. They're getting early help with certainly in the mental health sphere, and I think that's really important. So yes, those changes, and I do understand why the public would be concerned, but there are no acute beds in mental health that are being cut, right now. But that might change as the service develops, as we move that into the community. But so rest assured that there's the availability, obviously, in Manning Court.
You've obviously had some political reaction because there are some cuts in here, whether it be that it's a reduction in certain things like the beds you're talking about, which I understand is a phased approach, but things like the reduced spend on off-island provision, reduced spend on consumables, reduction in corporate service provision. I appreciate what you're saying about this all, down the line coming under the care of Manx Care here. But I suppose, Claire, for example, both Laurie Hooper and Julie Edge have come out quite vocally about this. They've both suggested that you wouldn't have agreed to the mandate document if you'd read it all. So did you read the whole mandate document before you approved it?
Of course.
And so the question that we then have is, would you 5 months ago as a backbencher, would you be supporting this document?
I think that absolutely I would be supporting this document. And I'm really glad you've asked that question, because this is the first time that we have, certainly from I think a DHSC perspective, where we're really aligning the mandate with the operational plan and our financial budget at the same time. And we've had to do that in, I think, about 6 weeks. It's been quite incredible feat to do that. And working closer with Professor Reid, working closer with the Manx Care Board, to deliver a service that's right for the public is really, really important. I can understand, that change is always really, difficult to understand, and I think that there's always improvements for us to communicate those changes better, and I'm definitely open to that. And I would just say that I absolutely welcome Miss Edge. She's totally always spoken to me about these, and communicated to me on these issues directly. Mr. Hooper, on the other hand, he's not come to speak to me about his queries or his issues. But again, my door is absolutely open, and I would welcome for him to come and speak to me, come and speak to Professor Reid, for us to talk through his concerns, especially for his constituents and the wider public.
Have you heard from your constituents at all?
In some obviously areas I have, yes. Back to the breast cancer screening, yes, I have had people from my constituency contact me.
Obviously, sorry, Wendy, I feel like I'm just on the political line here for a second. Obviously, these mandates aren't historically voted on by members. There is a debate coming forward about it, a general debate in the next sitting. If you were a backbench MP, would you want to have a vote on it? Would you be satisfied with the debate? Do you think that's going to be enough to air people's, grievances or questions?
So you're absolutely right. The mandate has always been, and that's all its statutory obligation is, to lay before Tynwald. And actually, that has what's been done by the previous minister for the last years that he's been in post. It's actually been backbenchers that have brought forward debates on the floor of Tynwald. I think the last one was brought by David Ashford, and actually no one else spoke but just him on the last mandate. So this is something that was committed by the Chief Minister when he was in the interim post. He committed that a debate would happen and it would be brought to Tynwald, and that's exactly what I'm following up with. I haven't done the vote yes or no, because basically from my perspective this is about communication, this is about working together. The debate is about them, other MHKs talking to me or talking in Tynwald and saying these are their concerns or these are the good things, and just to be clear on the process, if there is something that's overwhelmingly or was something overwhelmingly within the mandate that in listening in Tynwald that the majority of the MHKs felt that needed to be changed, that's a mandate can be changed within year. Obviously, it has to be in agreement with Manx Care. It has to be funded. It has to be make sure that it can happen. But that's what this conversation is about. The debate is about openly airing their concerns, our concerns, and yes, I would be welcoming a debate if I was a backbencher still.
I realise we're fast running out of time. I have one quick question. So just reading through it, obviously there's loads of things that jump out. What I did think was interesting is there's a line, I believe it's in the operating plan rather than the mandate, about the pressures placed on so getting our patients off island in helicopter or in patient transfer, and the issues that, because we're having issues staffing our air traffic control tower and how that adds to the costs and things. Do you think that this is the start of maybe Manx Care and the Department of Health being a bit more open about the financial pressures outside of Manx Care and the Department of Health, because air traffic control would fall under, more of a DOI remit. But you've made a point of saying, actually, this is an issue and this is how it impacts our spending. There's pressures on health spending that come from outside health as well. Do you think that that's a move more towards that?
I think one of the things that's really pleased me about this process, it has been very rapid and very intense, but it's been the honesty between Department of Health and Treasury colleagues and Manx Care colleagues and all of us trying to get the best result for the significant sum of public money invested in health and social care. And that really genuine recognition that we're not in a silo. You can't box off health or social care, and nor should we. And that genuine sense of integration and who does what and what the impacts are. And the more we communicate about that, the more we're open about that. And what we've put in our operating plan are where we see risk. And risk is something that we have to manage, we have to meet. But we have to do it in partnership with all sorts of people. And I've been very grateful for the support we've had from government to understand all of these areas of where we've got joint responsibility.
I think that you've raised a really valid point about outside pressures that we don't control. For example, that could be drug costs, or it's a really valid point, and there could be in-year uncertainties, which is why there is a 10 million contingency from Treasury, which we're working through the actual definitions of what can people that Manx Care can apply for that 10 million fund, but it would be, in essence, the strategy is that's there for any in-year unexpected costs, and I think that's really, really great, and that's probably great for Manx Care. I'm sure Professor Reid will say, in terms of, because we just don't know what's going to happen, we don't know what patients might present themselves throughout the year as well, and those additional costs that. Some costs. I mean, Professor Reid's, you probably give some examples of some high cost patients.
For example, in social care, a social care placement for an individual young person or child can be very, very expensive, and it has to happen now. And we obviously want the best for that individual. Those costs can be in the hundreds of thousands of pounds, and having a contingency plan that has rules around it that we can go to say this is out with our normal, I think we call them core services here, that's really helpful. Similarly, some of the new interventions in cancer care that maybe happens at the Christie, and there's an opportunity for a rare cancer to be dealt with in that way. Some of the gene modification techniques, they're coming fast, and inevitably somebody from the Isle of Man will benefit from that. We need to be able to make sure that individual has no idea that there's any problem at all. We've got a contingency fund, we'll go to that. And as we learn more about that, and we use our colleagues in public health and population health to understand, we can start to mitigate down the number of people that would require that and the number of times we go to that. But I was very keen that we had a sum of money that we could demonstrate to the public and to our assurance process through to the Department of Health and our Minister that we were using this appropriately.
Thank you for making it to the end of the Manx Radio Newscast. You are obviously someone with exquisite taste. May I politely suggest you might want to subscribe to this and a wide range of Manx Radio podcasts at your favourite podcast provider, so our best bits will magically appear on your smartphone. Thank you.